Welcome to the NeoFOCUS-UK Education Group webinar series.
Hello, everyone. My name's Jean. I'm part of the NeoFOCUS education team, and it's an absolute pleasure to be able to introduce our speaker today. She's Dr. Adrianne Rahde Bischoff from Iowa. She's a neonatal hemodynamic specialist and clinical assistant professor of pediatrics and neonatology. She's originally from Brazil and earned her MD there, as well as completed her pediatric residency there before pursuing advanced training in neonatal perinatal medicine at the University of Toronto's Hospital for Sick Children. She's later specialized in neonatal hemodynamics at the University of Iowa, and she's currently contributing to advancing research, education, and care for critically ill neonates. Dr. Bischoff is also an active member of the Pan-American Hemodynamics Collaborative and a council member of the Midwest Society for Pediatric Research. And we're very much looking forward to your talk today. Thank you so much, Adrianne, for coming to speak to us on this webinar.
Awesome. Thank you for the introduction, and mostly thank you for having me here today. Hopefully we can spark some good discussion after I give my talk. And today we will be talking on the topic of inhaled nitric oxide use in preterm neonates, which, as you all know, is a quite controversial topic nowadays, given the most recent AAP recommendations. I'm going to start with a case, and we'll give it a test here to see if this will work out. Have your phones ready to scan a QR code to answer a question once I finish with the case. So here we have a 24-weeker, 600 grams, and had preterm labor that was complicated by chorioamnionitis. The APGAR scores were 1, 4, and 8. The baby was intubated in the delivery room and received surfactant. Here at Iowa, our practice is to put them on high-frequency jet ventilator, but baby was on a mean airway pressure of 8, requiring 100% of oxygen, even after surfactant had been received. Preductal sats were 75, postductal 65, and there you have the blood pressure, the capillary gas, and the lactate of the patient. So there you go. You have the QR code. This should be fairly simple. You just scan and answer the question. I'm interested to see what is your next step in the management of this patient. I'll give you maybe a minute here or so to see if it's working. If I don't see any answers coming in, I'll just move on, or you guys can tell me to just move on. All right, so lots of repeat surfactant. Okay, we have at least one person there probably that said that they would trial some nitric. Start an inotrope vasopressor is also ranking up. Increase the mean airway pressure. Surfactant still kind of the main action that people would take, but a reasonable amount of you are saying that you would give this baby a trial of nitric oxide. Perfect. All right, so you are not a complete a group of complete non-believers, so that's good for me to know. Moving on. So when we talk about preemies, we're really talking about a wide spectrum, right? A 23-weeker is not the same as a 28-weeker. Their lung development will vary. We have comorbidities that will pile on, and the physiology can shift rather quickly. And pulmonary hypertension in these babies also doesn't follow a single pattern. We have different types, different timelines, and also different underlying causes. And much of what we know and how we approach treatment tends to gloss over a lot of these nuance. A lot of the evidence is kind of just pulling the data in a very simplified manner that doesn't take into account all of this. And that makes the science very messy, meaning that it's hard to create neat categories when the patients themselves don't fit neatly into these boxes. So let's start with looking at the pathophysiology of pulmonary hypertension in preemies. For those of you that don't know this guy, this is Darcy, and this is Darcy's law, which dictates that flow equals the pressure difference divided by resistance. And when we translate this into biological terms, what we see is that mean pulmonary artery pressure equals cardiac output times resistance plus the pulmonary capillary wedge pressure, which is the equivalent of the left atrial pressure. The most classic pathway that we think about that leads to an increase in pulmonary artery pressure is by an increase in pulmonary vascular resistance, which then follows a cascade of events that is sometimes variable, but can lead to an increase in right ventricular afterload, the potential for RV dysfunction, decreased pulmonary blood flow, shunts that are right to left at the PFO and the PDA level, hypoxemia, acidosis, VQ mismatch, and all of which can later contribute to also LV dysfunction. And the patients that are presenting with this type of phenotype are the ones that are most likely to benefit from nitric oxide use. We have some patients, however, that have LV dysfunction as the primary problem in their physiology. And through an increase in LV and diastolic pressure and secondary increases in left atrial pressure, this can be the main determinant for pulmonary pressure to be increased. And in this case, we don't have a problem of the blood getting to the lungs, but rather a problem of the drain just being clogged and can't getting out of the lungs properly. And in this type of situation, nitric could actually be harmful. There we have another subpopulation of patients that don't have elevated pulmonary vascular resistance. They have normal or even low PVR, which could exacerbate any shunt physiology that they could have, either PDA, ASD, VSD, and they can have increased pulmonary blood flow. And in these cases, the faucet is actually wildly open, and the increase in pressure is secondary to flow. And again, similar to the ones before, nitric oxide use can actually cause harm for these patients. Plus, if you combine, for example, patients that have flow-driven states, let's say the PDA, plus LV dysfunction, even if it's mild or mostly diastolic, then the potential for nitric oxide harm is even bigger. And the main problem that we face at the bedside is that sometimes it's hard to differentiate based on clinical parameters alone, which of the phenotypes the baby is presenting with. I'm not going to go into details because all of you know how nitric oxide works, but it works in the cGMP pathway. It vasodilates the smooth muscle cells in the pulmonary vessels, and it can improve ventilation perfusion mismatch by increasing blood flow to the ventilated lung units. So going back to this chart, nitric oxide will decrease the PVR, subsequently improve an entire cascade of mechanisms by improving pulmonary blood flow, decreasing RV afterload, and improving left atrial preload if you use it in this type of scenario. So let's walk through a case of precapillary PVR-driven phenotype. Here we have a 15-day-old 23-weeker presenting with suspected sepsis. The baby has worsening in respiratory status and oxygenation, despite escalation on ventilator support. And what you are seeing here on the echo was that the baby had suprasystemic pulmonary hypertension, had a right to left PDA and PFO, and had normal biventricular systolic function. What you can see here on this table, and I apologize if it's a little bit small, is that the FiO2, which is the line in purple, dropped from 73 to 65% when we started 5 parts of nitric. So then we increased the nitric to 20 parts per million, and the FiO2 continued to improve to 60, 50, and then finally 40%. And what you are seeing on the right are the changes in pulmonary blood flow. So on the top, we have the pulmonary vein flow velocities, which is just a surrogate for pulmonary vein flow. And you can see that the velocity is going up. And what you are seeing on the bottom is that the PDA, which was initially all right to left, now became mostly left to right. Now we have a different case. Here we have a 4-day-old 23-weeker whose FiO2 and ventilator requirements are getting worse. The team decides to start nitric empirically, and what happens is that the baby actually gets worse, needs an increase in mean airway pressure, has worsening oxygenation, and worsening lung fields on X-ray. When we scanned the following morning, we saw a large PDA that was 2 millimeters, had a pulsatile left to right flow, and had a QPQS that was estimated to be almost 4 to 1. And obviously, the scan was done after the therapy had been instituted, so I can't really tell you 100% for sure how it was before, but the dramatic features of PDA physiology, on top of this clinical worsening when the baby was started on nitric, raised the suspicion that the underlying physiology was actually flow-driven and not PVR-driven. Now we have another 23-weeker infant. I just picked a bunch of 23-weekers for this presentation. This baby is 6 days old, has a new onset Klebsiella sepsis. These are pretty generous high-frequency jet settings, and the baby is in a high FiO2. The baby is also very hypotensive, has lactic acidosis. Here you have the gas. We were asked to scan the baby, and what we saw initially was normal biventricular function and a bidirectional PDA. So the team said, it's pulmonary hypertension, right? So they are anxious at the bedside. They decide to start nitric, even though we hadn't completed our assessment quite yet. So they thought, okay, PDA is bidirectional. The baby's in 100% oxygen. This must be pulmonary hypertension. What happened is that the baby got worse. And what I'm showing you here are the other features of the echo, some of them, once we had completed our assessment. What this baby had was a hyperdynamic, underfilled left heart with normal function and normal to high cardiac output. You can see here that the VTI of the left ventricular output was actually quite big. The pulmonary vein flow is quite robust, and the baby had actually no other features on this echo to suggest that this was a PVR-driven pulmonary hypertension. Meaning there was no low pulmonary blood flow, there was no RV dysfunction, the septum was not flat, there was absolutely nothing else other than that bidirectional PDA. And in fact, probably this baby only had a bidirectional shunt because he was extremely hypotensive and had low SVR. So what this just shows you is that even if you do have echo, if you oversimplify echo features, for example, assuming that a bidirectional PDA means pulmonary hypertension, that can actually be harmful. And we have to be very thoughtful and understand that when you do a multiparametric approach and a thorough understanding of the physiology, then you are in a better shape to make decisions about the therapies and avoid harm on these type of babies. So why might nitric oxide not work as well in preemies? First of all, they have underdeveloped lungs. There's minimal pulmonary vasculature. There's minimal smooth muscle cells, which is where nitric would work. And if perhaps you don't have enough smooth muscle cells, maybe there's just not enough for nitric to act on. Second of all, the PVR in preemies is inherently high because their lung vasculature is still in the canalicular stage. And I'll show you a graph on the next slide about this. The biochemistry of preemies is a little bit different. They have reduced guanylyl cyclase activity, meaning that they can't produce enough cGMP, which is the molecule that nitric oxide relies on to relax the blood vessels. And they may also have low levels of vasodilators like prostacyclin and high levels of vasoconstrictors like endothelin-1. And then you also can add oxidative stress and immature blood flow distribution, which can also further impair nitric oxide signaling and limit blood flow to the ventilated areas of the lung. I really like this figure. This figure is from Satyan, who always grants us with amazing graphics. And it maps out the pulmonary vascular resistance, which is the blue line, as long as the structural lung development across the different gestational age. And you can see that the development of the pulmonary vascular resistance follows a U shape, which is very similar to these two graphs that are showing you data from NICU admissions and the use of nitric oxide across different gestational age groups. The top graph shows you the percentage of all NICU admits receiving nitric, while the bottom graph focuses on those that are requiring intermittent positive pressure ventilation. And what you can see is that nitric use is highest at the extremes. So either very preterm infants, less than 25 weeks, or the near-term infants, which are more than 37 weeks. And it's relatively low in that mid-gestation range, around 30 to 31 weeks. And what's important to know is that during the canalicular stage, which is the babies that we are talking about, less than 25 weeks, PVR is high because there's limited vascular development and there's also poor oxygen sensitivities. And there are fetal lamb studies that do confirm that at this stage, pulmonary blood flow doesn't increase as much in response to oxygen, which again just highlights the physiological immaturity of the vascular bed. Now, what is some animal studies that support the use of nitric in preemies. We have studies in preterm lambs, which are the equivalent of 24 weeks gestation, that show us that some of the biological mechanisms for pulmonary vasodilation are actually already in place at this early stage. So when they are exposed to 5 to 20 parts of nitric, preterm lambs do demonstrate a dose-dependent reduction in PVR and improved oxygenation because of better ventilation perfusion matching. They also do increase pulmonary blood flow and have a higher oxygen level. On the middle, you can see that endothelial nitric oxide synthase, which is an enzyme that is critical for nitric oxide production, is already functional by 24 weeks, and that demonstrates the lungs' capacity for vasodilation well before term. And then on the right, you can see that resistance arteries in preterm lambs do relax in response to nitric oxide donors, which again confirms the capacity for therapeutic modulation at this stage. And what I think is more remarkable about these findings is that they align very closely to what we do observe in clinical practice in human preemies, especially those that have hypoxemic respiratory failure and pulmonary hypertension. And when we leverage these biological mechanisms, we provide a strong rationale for the selective use of nitric, even in the smallest and most vulnerable babies that we treat. And what overall the animal data provides is biological plausibility and a mechanistic foundation to support the use of nitric in preemies when the pulmonary vascular disease is playing a role and helping us improve outcomes in what the carefully selected patients are. So when we decide whether or not to use nitric empirically for hypoxemia, it's important to put the pieces together. First, we're going to look at the clinical history and look for red flags that could be associated with pulmonary hypertension and elevation in PVR. So PPROM, chorioamnionitis, asphyxia, and so on and so forth. Then we're going to look at the hypoxemia itself and ask one question that I think is very useful is asking, is the hypoxemia disproportionate to the severity of the lung disease? So if you look at the X-ray and the oxygen levels are worse from what you would expect, then you have to think that maybe there's something else going on. The third thing is looking for a pre and post ductal sat gradient, especially if it's, 10, 15 points. And obviously, the absence of this finding will not exclude pulmonary hypertension because the duct could be closed, especially if the baby is older. Or they can also have significant intracardiac shunts, which will diminish the sign. But another caution is that if you have a gradient that is bigger than 20%, it could be a sign of either congenital heart disease or severe LV dysfunction that is duct dependent and in which nitric could be harmful. So it's a reasonable clue, but if I get a really, really large gradient, I'm actually going to be more cautious than not. And then finally, you can look at other cardiovascular signs, for example, hypotension, lactic acidosis, poor perfusion, which also can paint a broader picture into what's driving the hypoxemia. And if you put all of these clues together, that can help you guide a little bit more whether nitric could be the right move or if the problem is something else. The question that people ask me is an echo mandatory before starting nitric oxide? And in an ideal world, of course, I would love for every preemie to have an echo, a complete echo, a targeted neonatal echo before starting nitric, even more than the term babies where the physiology seems to be a bit more homogeneous. But I guess you all know that this is not the kind of world that we live in. We don't have unlimited resources and availability necessarily. And therefore, I don't think that an echo is necessarily mandatory, but I do think that it certainly refines precision care, which is what we all aim to do as best as possible. One of the concerns with starting this therapy in babies is not only if they wouldn't benefit, but also if they could be harmed by it. And other than the flow-driven and the left heart phenotypes, one consideration is in the case of previously undiagnosed congenital heart disease. This is a study that was not done in preemies, but it was done in the transport setting in babies that had hypoxemia, and they were looking at the decision to start prostaglandin for presumed congenital heart disease or nitric oxide for presumed pulmonary hypertension. They used kind of these guidelines to establish if the baby was more likely to have pulmonary hypertension or congenital heart disease. One of the highlights here, I apologize, was that if the baby has low SATs in the absence of significant respiratory distress, if they tolerate room air, or if they have other additional features that can raise the suspicion for congenital heart defects, those are kind of the most important ones on this side. Whether for pulmonary hypertension, and again, I highlighted that these were mostly term kids. Hypoxemia that is more likely to present with lability, intolerance to weaning the oxygen, and some abnormal lung parenchyma. These would trigger them to think more in the pulmonary hypertension domain. Well, so they categorized these hypoxemic babies on transport. Those with suspected congenital heart disease were more likely to have a murmur, cardiomegaly, what they thought was an abnormal heart shape. They were more likely to have an upper and lower limb blood pressure gradient. And the ones that had suspected pulmonary hypertension were more likely to be hypotensive and to also have abnormal lung parenchyma. And when they used these parameters, they were accurate in 88% of the cases, which I think is pretty good. So bottom line is, I don't think without an echo, we won't get it all right. But if we are truly thoughtful, we may be able to differentiate to some extent whether the baby is truly a PVR-driven pulmonary hypertension, which can benefit from nitric oxide, versus the other pulmonary hypertension phenotypes, congenital heart disease, or predominantly lung parenchyma disease. So let's look at two different cases. Now I got 24-weekers who are stuck in a lot of oxygen. Baby number 1 is a 6-hour-old that is born after an emergency C-section. Baby has low APGAR scores and is acidotic after birth. Baby initially responds to surfactant, but the FiO2 increases again in a few hours. The baby is hypotensive, has a pre- and post-ductal SAT gradient, and a high lactate. And in this case, I think precapillary pulmonary hypertension is very likely, and nitric is most likely to work. Baby number 2 is a 5-day-old who is sectioned because of maternal reasons, is steroid complete. Baby is doing pretty well in the first few days, responded to surfactant, weaned down to room air. Over the next couple of days has progressive increases in FiO2 to 21, then 50, 80%, has also increase in oxygen needs and in ventilator needs, mean airway pressure. The baby is not hypotensive, does not have a split, how they say here in the US. And in this case, I think all points out that the physiology is most likely to be a PDA that is becoming significant, that is left to right. And nitric should not be used, at least not without an echo first, to confirm that that is the most likely problem going on. And what if you start and the baby either didn't get better or gets worse? Well, first of all, instead of blaming it on the baby, admit that maybe is your mistake. It's not the baby that was bad or the disease that was bad, and you can just stop the nitric. Sometimes it's not as clear-cut, obviously, as these cases. I put very obvious ones, but we are humans and we won't necessarily get it all right. But if we keep insisting in that mistake and hoping for a different outcome, that is the absolute definition of insanity. So if it didn't work, maybe we should consider that we got the wrong physiology and we should just stop what we started. And one of the good things about nitric is that you can turn it off rather quickly and be done with it, right? So we have to remember what our biases are and think about what is happening to the patient instead of just insisting and blaming that the baby is just bad. Here we have a 26-weeker with a similar case from the case number 1. This was a baby born outside, had suboptimal birthing conditions, had a delayed resuscitation, and had poor APGAR scores. Baby comes to us on transport on some epinephrine because he was hypotensive and is in high oxygen requirements. And here you are seeing some of the features of the echo on arrival, which showed a moderate PDA, which is the picture that you were looking at, with an almost all right to left shunt. The baby had severe RV dysfunction and had a low cardiac output state. Here you can see the evolution of this patient. We also started the baby on some vasopressin because he was still hypotensive when he came on. And once the nitric was started, the FiO2 immediately went down to 70%, and within an hour, the baby was down to 21%. And then we left for the day. And what happened overnight is that the blood pressure, which was being measured in the umbilical artery, was going down, And what the overnight team did was continuing to titrate up on the drugs that the baby was receiving. The next morning, we came again and we scanned the baby. And now what we found was all features of a left to right significant PDA. The baby had left heart dilation, had diastolic flow reversal in the descending aorta. And so truly what we were seeing here was the effect of systemic steal from the PDA causing the postductal hypotension. And there's nothing in the literature about this, but I see this all the time, especially in the babies that get nitric and that the FiO2 improves dramatically. That is frequently followed by a period of low blood pressure in the UAC. And whenever I come to scan these type of babies, I essentially always find that the PDA has now flipped in the other direction. And instead of adding or increasing vasopressors, what the management should really be is to take off the nitric, which is now contributing to drive the shunt in the opposite direction. So what we did the next day was that we weaned the nitric quickly down to 5 and then to off. And in just a few hours, you can see that the blood pressure stabilized and the team was able to continue to wean on the vasoactive medications. This brings me to the next point, which is when and how do we decide to wean? Number one is when it didn't work. It's probably the wrong therapy. Maybe you got the wrong guess, and it may not only not be helping, but it could also be causing harm. Number two is when it did work, but now you achieved your goals. There was a clinical and/or an echo improvement. And remember that the goal may not necessarily to get down to 21%, because we don't want to necessarily over-treat the patient and go to the other extreme. I see in my practice a lot of fear about weaning too soon. People tend to be very fearful of pulmonary hypertension. And people will tell me, well, what if I wean and then the baby goes back to 100% of oxygen? And what most often happens is that people tend to be afraid of these sick babies and think that if the therapy worked, they should just keep it. But there are some circumstances where that could be true. There are babies that have bad pulmonary vascular disease that may need it for longer, but that's really not the reality for all of them. And you can only know that by either doing an echo, which has precise information to know, where the physiology is at, or if you can't get an echo right away, or if the echo that you are getting is not really giving you enough information, you just have to try to wean it and see what happens. And I believe that people should be just as fearful about maintaining a therapy than taking it off, because new problems can appear. So you can have iatrogenicity related to keeping the drug for too long, and you have to monitor what happens when you start weaning. So then number 3 and number 4 come together, which is when a new symptom or problem that could be attributed to a new iatrogenic use has now appeared, like the case that I just presented, where the baby had new worsening of systolic hypotension, which indicated that the physiology evolved into something else. The next question that people ask me is, how fast do we wean? And to be clear as mud, we don't actually know the answer to that. But here's the thing, and I don't think I can highlight this enough. It's not enough knowing when to start nitric and in which patients to use it, but we also have to know when to stop it. And we have to do sometimes in a relatively quick fashion, especially in the preemies that the PDA is still open. When we're moving from a state of high PVR and low pulmonary blood flow to now low PVR with a sudden improvement in pulmonary blood flow, we are also changing the PDA direction, which will further increase pulmonary blood flow. So that changes the physiology from a low cardiac output state to now a high pre-ductal cardiac output state with increased cerebral blood flow, and that increases the risk for ischemia reperfusion type of injury, specifically IVH. And this risk is obviously higher in the preemies than in the term babies, even though the physiological changes are exactly the same, because of course they have the immaturity of cerebral autoregulation and they have a higher vulnerability of the germinal matrix. In addition, the sudden increase in pulmonary blood flow, especially in the babies that have inherent diastolic dysfunction of the LV, is what I showed before by adding 2 physiologies in which nitric can be harmful. Flow leading to increase in left atrial pressure, and increased LV and diastolic pressure reflecting into high left atrial pressure as well. And this also brings the patient at higher risk for pulmonary hemorrhage. And finally, this brings me to another point, which is what should be the starting dose of nitric. And again, there's very few studies that look at this. And to be completely honest, they're just not granular or homogeneous enough to make any meaningful conclusions. But I will say that although as neonatologists, sometimes we feel very satisfied when there's rapid, dramatic changes that shows us that the baby is improving, in reality, some of these big jumps and shifts, especially in the cardiovascular system and especially in premature babies, have burned us in the past. So I personally practice in a more thoughtful way where I try to be more patient in manipulating the physiology and the changes in resistance and pressure. So I usually start nitric at 5 parts per million and I monitor the response. If it didn't change anything, then I go up to 10 and then to 20 every 5 to 10 minutes. And if at 20 parts per million, it continues to not work, or if the baby gets worse, whether FiO2 or some other parameter, then I simply wean it and I stop it within a couple of minutes, which means that I just stay at the bedside whenever I'm starting nitric for a premature baby, and I am there for at least the first 15, 20, 30 minutes to see which direction things are going to go. I don't have any scientific data to prove any of this, but I have seen many, 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 many babies in our practice who respond both clinically and echocardiographically at 5 parts per million. And the shifts in physiology seem to be less dramatic, and we seem to have less complications with IVH, pulmonary hemorrhage, and so on and so forth. So why is there still so much debate about nitric? It's not really about whether nitric works or not. It's about how we decide who it works for. So if we hear a lot of these statements like nitric hasn't been proven to change outcomes, these conclusions actually come from studies that lump together a very wide range of babies, despite how different they really, really are. And this is not to say that RCTs are not important. Of course they are. But when they don't account for things like gestational age, timing, lung disease, and most importantly, phenotype of pulmonary hypertension, we lose the detail that matters in real-world decision-making. So I think that instead of asking if nitric has been proven or not proven, maybe the better question is, how can we use the evidence more thoughtfully in the context of each baby that is in front of us? The evidence from, systematic reviews and RCTs will tell us that there's no significant reduction in mortality or BPD. The composite outcomes show inconsistent minor benefits. Early nitric has the potential to increase severe IVH, even though those results were not necessarily statistically significant. There's a lot of heterogeneity in the protocols, like I said, dose, timing, duration. There's very small, not robust subgroup analysis for babies with pulmonary hypoplasia or PVR, pulmonary hypertension type of phenotype. The conclusion is that evidence does not support routine use of nitric for preterm infants with hypoxemic respiratory failure, but there are some specific groups that may benefit, even though these populations remain underrepresented in the study. But I think most importantly, as Keith Barrington puts it, and he's one of the authors on one of these on the Cochrane review, is that the data shows no overall increase in survival. But that's not the same to say that there are never indications. And I think that's the space that we're in, where we're trying to figure out when it might help and for whom. In real world practice, even though these guidelines advise against routine use of nitric in preemies, the use has actually gone up, especially in the most immature babies. So this is a study that shows from 2009 and 2013 that nitric use in those that were born between 23 and 29 weeks increased by 23%, even after the NIH consensus recommending against it. And by 2013, almost half of all nitric use was off-label, mostly in babies that were under 34 weeks, and which are especially the sickest and most fragile ones. And my explanation for this is that likely in certain situations where severe pulmonary hypertension or lung hypoplasia are present, there just are not many options. And in those moments, even if it's a short-term increase in oxygenation, that can feel critical. And obviously, this is not going to show benefit, but it does highlight that clinical urgency often drives decision when the evidence is giving us some gray zones. Now, let's look at some other studies that actually support the use of nitric and show us that it does work. This is a multi-center study from Canada looking at nitric responsiveness in preemies. They had echo data available from 3 different sites, and what they found was that 56% of the infants were classified as responders. They found no significant differences in antenatal or baseline characteristics between the responders and the non-responders, but the responders tended to receive nitric oxide at a younger postnatal age and showed a trend towards lower systolic blood pressure at the time of initiation. And among those infants that were under 72 hours of life that had documented pulmonary hypertension on echo, the response rate was actually 82%, which is pretty high. The pulmonary hypertension was identified in 73% of this cohort and was a strong predictor for nitric response. So responders were more likely to have pulmonary hypertension and to also have higher baseline pulmonary hypertension severity score. And having pulmonary hypertension increased the odds of response by 5-fold or even 8-fold if pulmonary hypertension was confirmed by targeted neonatal echo. Responders more often showed moderate to severe right ventricular dysfunction. Non-responders had more moderate to severe LV impairment. And although survivor was higher amongst nitric responders, those babies that were less than 28 weeks who responded to nitric, unfortunately, did have a higher rate of severe IVH, which for me is just a signal that the physiological benefit doesn't necessarily come without trade-offs if you are not being mindful and thoughtful about when to wean the nitric. This is a study here from the University of Iowa that looks at a very underrepresented population, which is the babies born between 22 and 26 weeks. And they grouped the babies based on oxygenation response to nitric in either responders, non-responders, and a very interesting group, which is the negative responders, whose oxygenation worsened after they got nitric. You can see that the rate of positive response is very similar to what we see in term babies. And the responders tended to be younger and were more likely, again, to have echo-confirmed pulmonary hypertension around the time that the nitric had been started. The negative responders were more likely to have a PDA or sepsis. We already talked about how PDA can interfere with response, but sepsis is also an important one. And when we have elevated inflammatory cytokines and oxidative stress, that can blunt the effectiveness of nitric or even worsen the outcomes by amplifying injury. The responders had a lower risk of severe BPD and a composite of BPD or death. They also needed fewer days of positive pressure support and had lower rates of severe ROP when they were compared to the negative responders, which possibly reflects the reduced oxygen toxicity. The non-responders had more significant lung disease, whether atelectasis, consolidation, where nitric simply cannot reach the distal vasculature. So if you have no vascular dysregulation and no VQ mismatch, the nitric is unlikely to help. This is a 2018 registry study that shows that rapid and sustained oxygenation improvement happens when nitric is used across all gestational age, and the greatest gains are in those that start with a higher OI value. And the average drop in OI is similar in the term and the preterm infants, again, suggesting that when we use selectively, nitric can have comparable physiological effects across gestational age groups. This is a meta-analysis looking at babies less than 34 weeks that had a hypoxemic respiratory failure and suspected or confirmed pulmonary hypertension. They had 5 studies, including 400 babies, and those who showed oxygenation improvement within 6 hours had significantly lower mortality, especially if nitric was started within 72 hours. And while the evidence here was rated as moderate because there was obviously a lot of study differences, this again suggests that responders may have better outcomes. And I think that this highlights a gap in the older trials that excluded these high-risk patients. This is a single RCT that evaluated whether treating early pulmonary hypertension on echo without hypoxemic respiratory failure would improve outcomes. This was a study that was stopped early because the interim analysis showed no benefit. And while I think it's very tempting to read this as a nitric doesn't work, most of the babies in this study didn't even have respiratory failure. So even though they had pulmonary hypertension definitions based on echo, there were a lot of limitations if you look at the nuances of this study in terms of the phenotypes and the severity. meaning that the takeaway for me is that the study only asked an important question, but the population does not really reflect those babies that actually typically benefit from nitric oxide. There were 3 studies that I could find that examined nitric costs. The most recent, which is from Satyen, showed a median cost of $7,500 per patient. There's a UK study that found that the cost was even lower. And then there is one trial that compared overall costs in infants treated with placebo versus nitric between days 7 and 14. And the average cost was actually lower in the nitric group, along with better outcomes. And in that subgroup, there was a 71% chance that nitric reduced both the costs and the morbidity of the patients. So even though nitric may be expensive upfront, it may lower total NICU costs by shortening ventilation and length of stay, as long as it's used thoughtfully. Neonatal care demands that we lean into the complexity, and I think that future trials need to reflect the real-world variability that we see at the bedside. And that means that we want to stratify patients based on their physiology, not just gestational age. And until then, we have to make the best decisions that we can with imperfect data and keep pushing for smarter and more targeted studies. Thank you.
Thanks, Adrianne. That was fascinating and a wonderful summary of the use of nitric oxide in preterm babies. So if anyone has any questions, can you please pop them into the Q&A?
Brilliant talk, Adrianne, as always. Thank you very much for that.
My pleasure.
While we're waiting for, sorry, Jean, you're muted.
Oh, yes. So whilst we wait for the questions to come in, I'll just introduce our expert panelists. So first we have Dr. Mahmoud Muntasser, who's a consultant neonatologist in Scotland, as well as with the ScotStar Regional Transport Service in the UK. He's the co-founder and national chair of the NeoFOCUS group, which is a special interest group for neonatal functional hemodynamics and point-of-care ultrasound. He's taught on many national and international conferences and workshops, and he has research as well as QI interests in neonatal hemodynamics, postnatal transition, cardiopulmonary interaction, as well as POCUS. So thank you so much, Mahmoud, for being one of our panelists. And we have Nims Hedar as well, who's a consultant neonatologist in Liverpool. He is a clinical senior lecturer with the University of Liverpool, and he actually has quite an extensive research portfolio on pulmonary hypertension, inhaled nitric oxide therapy, neonatal hemodynamics, and echocardiography. Quite exciting that he previously led the first randomized controlled trial on inhaled nitric oxide in preterm neonates, and he was a co-applicant as well for the UK multi-center trial Baby Oscar, and he's currently chairing the International Registry of Pulmonary Hypertension in Neonates, REFINE. So thanks. So it looks like we've got a question in the chat.
Hi, Jean, do you think you could enable my video? I think you've stopped it. I'm not hiding. So shall I go first, Mahmoud? Can I, great. So Adrianne, thank you very much. That was a wonderful walk through nitric oxide in preterm babies. Amazing. I learned a lot. And the first question is something that I was going to ask you about as well, which is a question about dosing of nitric oxide. And the question is, do you routinely choose to start nitric at a dose of 5 parts per million in all or most of your preterm babies? And my question was going to be the same, because I'd heard that in Iowa you do use 5 parts per million in preterms, but 20 parts per million in terms. Is that right? Perhaps I've got that wrong.
Yeah, no, you got it right. I mean, the term literature, I think, is robust enough that we just stick to the usual and just do 20. But we've started doing 5 parts for essentially, I'm not going to say all, but most preemies as a starting place. We might escalate rather quickly if we're not seeing a response, but we've seen so many that at 5 parts you're already seeing improvement, that we've decided, why would we give them the higher dose if they are already responding to a lower dose? Sometimes less is more. So yeah, routinely we do start at that. That doesn't mean that all of the babies stay at that. Some of them do need a little bit more, but we try to aim for the lowest dose necessary to achieve clinical and or echo improvement. So I would say that for the most part, we are starting at 5 parts for especially the micropreemies. I mean, if it's a 34-weeker, it's close enough to term, we might do 20. But for a 26, 25, 23-weeker, I think most of us are practicing at 5 parts per million.
Okay, that's interesting. I'm guessing that's different to what most people in the UK do. So, that's a bit of an eye-opener. Thank you.
Absolutely, I agree with you, Nim. But I think nowadays we're kind of more physiology-based driven management. I think it makes sense what Adrianne is saying, because if you give high dose and cause abrupt reduction in PDR and flood the lung, from a duct that is there, you're going to precipitate pulmonary hemorrhage and IVH, which makes sense. With lots of baby, actually, we started nitric, developed those 2 complications. Probably because, we just go with a routine 20 parts per million, but maybe we should just shift now to a lesser dose and try to tailor the response as already illustrated in your cases. Yeah.
Yeah, if I'm doing a consult as the hemodynamics consultant and I identify a baby that we should try nitric, I just say, okay, just bring the nitric. I'm going to stay here and I'm going to monitor. If I want to do some additional images, focused imaging, cardiac output, pulmonary vein, ductal flow, I might stay there for those initial 15, 20, 30 minutes and kind of titrate the medication as needed. And if they don't respond at all, which is unusual, because if I do find that they have elevated PVR, low pulmonary blood flow, the typical pulmonary hypertension phenotype, most of them do respond to some dose of nitric, whether it's 5, 10, or 15 or 20. But I do stay at the bedside, which is not something that I necessarily do with term kids. Term kids, I diagnose, I say, okay, put nitric at 20, call me if you need me, and then I walk away, right? Because it's just more predictable. The preemies are not quite as predictable, and I prefer to be more cautious and stay there and watch what's going on myself. People, if they're not staying at the bedside, are hard to report to you exactly what happened. The nurses are charting at the same time. They may not exactly be watching the nuances of what's happening to the SATs, the FiO2, the blood pressure. So I just do it myself.
And I suppose also the latest guideline from the Canadian network, they supported that approach. So they said in preterm babies, you can start by 5 or 10 and increase according to response, or wean if no response, if that makes sense. Questions are coming in now. So there's a question about any cutoff to start nitric in preterm babies. I suppose they're referring to OI number, for example, or any arterial gradient. So in terms of babies with hypoxic respiratory failure, would you start nitric at certain FiO2 or certain kind of severity, if you like?
That's a good question. I don't know if there's any guidelines on that. Personally, here at the University of Iowa, there's no obvious cutoff. I think it's more like common sense. I don't think anyone would start nitric on a baby who is on less than 50% of oxygen, unless they had other cardiovascular issues that are being caused by elevated pulmonary pressures. Let's say the baby has severe RV dysfunction and has elevated pulmonary pressures, and maybe I do need some afterload rejection to the RV to improve the overall hemodynamic state. But I think for the most part, we reserve it to the babies that are truly hypoxemic, most commonly 60 for FiO2 and above, but the obvious ones are the ones on 80, 90, 100% of oxygen. But we don't necessarily calculate an OI or an AA gradient. It's a combination of both clinical and echo. Also, if we find echo features that are of significant pH, even if they don't have terrible hypoxemia, we might do it, but that's fairly uncommon. Usually they come hand in hand.
Right. There's a question about non-responders to nitric. And the question is, in non-responders, can you share your experience with what pulmonary vasodilator therapies you use, including the use of milrinone in this group of patients?
Yeah, that's a great question. And I'm assuming that you are asking specifically for the babies that have the correct phenotype but don't respond, which are a small proportion, as we saw from one of the studies I presented. If you do have the right physiology, and as long as your lungs are open, because if the lungs are not open, if they're not well recruited, then nitric is not going to get to the pulmonary vasculature. So that's consideration number one. But if there is a baby that is truly a nitric non-responder in the correct physiology and under the correct circumstances, we do use milrinone fairly frequently. Sometimes if they have a contraindication to milrinone, meaning a baby that hasn't started peeing yet, that has acute kidney injury, or that has severe hypotension, where milrinone could actually drop the blood pressure even more. Sometimes we have used prostaglandin, not necessarily as a ductal patency agent, but as an additional pulmonary vasodilator. So I would say that in the acute period, those are probably our most common drugs. We use nitric and milrinone simultaneously quite frequently in the severe pulmonary hypertension, whether they are non-responders or kind of responders, but not to the extent that I wanted. You know, they usually respond a little bit, but just not enough. And then I add milrinone on top. So yeah, that tends to be a good combination of drugs, as long as there's no contraindications for milrinone.
You mentioned in your one of your cases that you presented the use of vasopressin as an adjunct, as a pressor agent. Some people in the UK would use vasopressin, some people use noradrenaline. Have you got any preference of one over the other, and if so, why?
If there is significant pulmonary hypertension and significant hypoxemia, our preference, if I need an agent to literally just increase the blood pressure, it would be vasopressin, because we have some animal and human data that supports that vasopressin might have a better profile in the pulmonary vasculature. Norepi is reasonable. It's definitely better than dopamine. But norepi in hypoxemia can also increase PVR. So in those babies that are stuck in 100% of oxygen, the really, really sick ones, our usual preference is vasopressin. If they're the moderately sick and people are a little iffy or worried about vaso and the sodium and all of that, sometimes I'm okay if they do noradrenaline instead. But our usual first line vasopressor in the very sick hypoxemic term or preterm infant is vasopressin.
I'm glad you said that, because that's what we do as well.
Good.
So there are a couple of questions on the same topic, actually, about when you initially start the nitric for high PVR, then the physiology switched to flow-driven pulmonary hypertension. How you monitor that, and how you build your strategy essentially and wean the nitric or not?
It depends on what the time of the day is, what the resources are. Is it a week or a weekend? If it's during the week and it's business hours where our hemodynamics team is around, we will try to do more with echo guided. We might start nitric in the morning, repeat the echo in the afternoon, and then provide really objective information about the weaning and the physiology that is going on. But if it's a baby that came at 5 p.m., we scanned, we recommended nitric, we may not necessarily have someone here overnight to be guiding that decision. And we will provide some parameters clinically, meaning decrease in FiO2 significantly. Let's say if the baby is in 100%, you start nitric and they start getting better, we might say, look, when the baby gets to 40%, start weaning the nitric. And we'll see how things look tomorrow. Or if you start seeing post-ductal hypotension, even if your FiO2 is not completely better, maybe that's a sign that the physiology is shifting in a different direction. Maybe it's time to, instead of starting a new medication, maybe start weaning. So we might give them some parameters in that regard of clues as to the physiology might be shifting in the opposite direction. We always say that it might be interesting, we don't use it, but it might be interesting to monitor non-invasive cardiac output. If all of a sudden you see that the preductal cardiac output is going up, then that might be a sign that the PDA is becoming an issue, and maybe that's the time to wean. But that's all speculative. We don't do that in our clinical practice, but I think it would be an interesting use of non-invasive modalities that are continuous monitoring to decide. So it depends. It's a combination. I don't think you need an echo to stop nitric. I think if there's enough clinical reasons that things look better, it's time to wean it off before we run into more problems. That's kind of what we recommend.
We have a question about the timing of death in babies who are preterm and have received nitric for hypoxic respiratory failure. In this centre, the observation was that babies who received nitric in that setting died 2 weeks later than babies who didn't. So the question that is being asked is, does nitric delay the death of extremely vulnerable preterm babies? So there's no improvement in survival, but you're just delaying when the baby dies. Is that a fair comment, do you think?
I mean, I don't know the details. I wonder if it's related to IVH or a PDA that became significant and that the baby developed neck. I wonder if it's pulmonary hemorrhage. It could be a bunch of morbidities related to the physiology shifting the other way, not being recognized and delayed weaning. That could be a reason for it that I could easily speculate. It's hard to say without seeing the data and why these babies died. But yeah, you can have a bunch of all-cause mortality that still have the initial insult being a PDA that is too significant and that is causing steal and causing problems. We don't see that in our practice. Typically, the same as the studies that I presented and the meta-analysis that I presented, if the babies are responders and then we wean them, typically they survive. I don't see them dying a little later or anything like that.
And along similar lines, I mean,
I would be interested to hear more about it.
Sure. Along similar lines, one of the most striking messages from your talk was the importance of precision-based medicine or individualized care. And you touched on how you might differentiate resistance-driven versus flow-driven versus left heart disease as being the underlying reason for pulmonary hypertension. But could you say a little bit more about not so much flow-driven versus resistance-driven, because the example you gave were two different sorts of babies. But if you have acute pulmonary hypertension in the first 12 hours, let's say, how can you differentiate between resistance-driven primarily and or a component of left heart disease and left ventricular dysfunction? And I suppose a follow-up question there is, I think you're going to say some sort of echo parameter, but which parameter would you use to assess LV function, systolic and diastolic?
I wasn't actually going to start with echo parameters. I was going to start with clinical and risk profile. Some of the babies that we have noted anecdotally that you would anticipate that they would have a PVR driven, but sometimes they actually have left heart driven phenotype are some of the severe pulmonary hypoplasia babies. And I wonder if part of those babies, at least in the initial, the very initial transitional period, if they have a physiology that is similar to some of the diaphragmatic hernias, where because they have pulmonary hypoplasia and they have even less pulmonary blood flow in utero, because they have less preload to the left heart, they have kind of underdeveloped left hearts, which then leads them to have a predominant left heart physiology rather than PVR. Those are a population that I used to think, oh, pulmonary hypoplasia, it must be nitric responders. And I've seen enough babies that actually have left heart phenotypes that now I actually pause before I start on those kind of babies. Now the typical, it's an asphyxiated babies. The baby had poor Apgar scores. Those most often tend to be the traditional PVR type of phenotype. So I think clinical history and risk factors kind of matter. The second one is what I mentioned about the pre and post ductal SAT gradient. The gradient is really, really, really high, 20%, 25%. That makes me think more about left heart instead of right heart disease. Again, anecdotally, I don't think there's any science out there, but I think the cardiac output is so low from the left heart that you might see a bigger gradient in the SATs. That makes me think more of left heart instead of right heart. And therefore, those are the babies that are more likely to do an echo before I start nitric. And then again, on echo, they would always have both phenotypes in a very sick baby. They will have a bidirectional or a right to left PDA. And then you have to look at heart function. So are they predominantly left heart dysfunction, Simpson's, ejection fraction, fractional shortening, tissue Doppler, or are they predominantly an RV dysfunction phenotype? TAPC is low, RVS prime is low, RV FAC is low. And then another clue is the direction of the atrial level communication. So if you have a baby who's in 100% of oxygen with a completely right to left ductus, but the PFO is left to right, that cannot be right heart disease. That has to be, to some extent at least, left heart disease. And you have to treat the left heart disease first. That's not to say that they won't need nitric later on, because sometimes when you fix the left heart, they still have residual PVR disease, and you still have to treat them with pulmonary vasodilators, but you have to treat the left heart first. And that's typically what happens with my pulmonary hypoplasia patients that I started talking about. I sometimes find them with a severely depressed left heart, an ejection fraction of 40, 50. I give them epinephrine first. They have some improvement. I scan again. I see that the left heart has improved, but the pulmonary hypertension is still bad. They're still not great. And then I give nitric after that. So I think those are some of the clues and things that I've seen in practice that kind of guide me one way or another. And if people call me to do a consult, I go through kind of these exercises in my head to see, okay, maybe they can do it empirically, or okay, fine, I need to go in and make sure that they have the right one before they start the therapies. So those are probably the main key points.
Thank you.
Fantastic. So I think we've had a very interesting and inspiring talk from you, Adrianne, and lots to take home in terms of thinking about our practice and how we can optimize outcomes for our babies, and lots of interesting questions and points for discussion. So thank you everybody for joining our webinar. The feedback links in the chat, and you'll get a certificate of attendance as well with that. Thanks very much.
Thanks for having me.
Thanks.
Bye-bye.
Bye.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.